Hello and welcome to Parkinson's 101, What You and Your Family Should Know. I'm Nancy Nealon, Senior Community Program Manager for the Parkinson's Foundation, New York, New Jersey chapter. On behalf of all my colleagues, we want to warmly welcome you to our webinar today. And now I'd like to take just a moment to share with you the important mission of the Parkinson's Foundation. At the Parkinson's Foundation, we work every day to make life better for people living with Parkinson's disease by improving care and advancing research towards a cure. We are the nation's largest community for people living with Parkinson's. And everything we do, we build on the energy, experience, and passion of our global Parkinson's community. To achieve our mission, we pursue three goals: to improve care for everyone living with Parkinson's, to advance research toward a cure, and to empower and educate our global community, such as we're doing right now. In addition to our goals, I'd like to share with you information about all of the free resources that we have. You see some of them there on the slide, and I am holding some of them here to give you another view. Many books, educational books are important. Aware and Care Kit. These are all available to you. You can call our helpline 1-800-4PD info. Visit our website, parkinsons.org, to learn more, to order your copies. I also like to highlight one of our really important national initiatives, PD Generation. This offers free genetic testing and counseling to anyone diagnosed with Parkinson's disease. You can participate in person at a Parkinson's Foundation Center of Excellence near you, or with an at-home cheek swab and telemedicine appointments. For more information about this, please visit parkinson.org/PD Generation. Another opportunity for you to participate is that we started a special initiative meant to capture the community's perspective on various topics in Parkinson's disease, such as mental health, telehealth, cannabis, and more. By signing up for this initiative, we will email you up to 4 times a year, requesting that you complete a 10 to 20 minute survey. And we will always report our findings back to our community. Like today's webinar is part of our PD Health at Home, I encourage you to check out all that we offer. This is a weekly series: Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. And we record all our webinars, so they're available to watch at your convenience later on. Would also like to take this opportunity to highlight for anyone who is caring for someone with Parkinson's who is part of their team, their care team. We will be holding our 2022 Care Partner Summit that will bring care partners together in person and online to provide them with tools and resources to make life better for themselves and their loved one living with Parkinson's disease. With a focus on managing evolving roles and identity, understanding possible thinking changes in Parkinson's, attendees will learn the importance of self-care and have the opportunity to connect with other care partners. You can attend in person or you can watch online. Please visit parkinson.org/summit to learn more. And now it is my great honor to introduce our guest speaker. I would like to introduce Dr. Michelle Fullard. Dr. Fullard is a movement disorder neurologist at the University of Colorado. She completed her undergraduate and medical school education at Vanderbilt University. Following medical school, she completed her neurology training at the University of Virginia and movement disorders training at the University of Pennsylvania. During her fellowship, she also received a Master of Science in Clinical Epidemiology. In 2018, Dr. Fullard joined the faculty of the University of Colorado, where she is the Director of Research for the Movement Disorder Division. Her research focuses on gender disparities and care for women with Parkinson's disease. And with that, Dr. Fullard, welcome today. Thank you so much for being our expert speaker. And I invite you now to share your screen. And I will be back for our Q&A session when you're done. Thank you.
Great. Well, thank you, Nancy. And thank you everyone for having me. So as Nancy said, I'm Michelle Fullard. I'm a movement disorder neurologist at the University of Colorado. And today we'll be talking about all the basics of Parkinson's. So to begin with, this is just an outline of what we'll cover today. We'll talk about what Parkinson's disease is, what causes Parkinson's, the various symptoms that can occur, how we manage Parkinson's, and then Parkinson's and research. So just as a quick overview, so Parkinson's is a progressive brain disorder or a neurodegenerative disorder, meaning it's caused by the loss of dopamine neurons deep in the brain. And there is no cure for Parkinson's. However, the symptoms can be treated and treated effectively. And in addition to medications and other treatments, there are also healthy lifestyle choices that can help maintain quality of life for people with Parkinson's. So what you'll hear throughout this talk is that with the right care, the right support, the right resources, people with Parkinson's can live well for many years. Okay, so we'll get into it. So who gets Parkinson's? In the US, we think there's about 1 million people living with Parkinson's and about 10 million worldwide. And it's estimated that by the year 2040, that number will almost double to about 17.5 million people worldwide. Currently in the US, there's about 60,000 people who are diagnosed each year. And this makes it the second most common neurodegenerative disease besides Alzheimer's disease. And when we think about Parkinson's, anyone can get Parkinson's, regardless of race, ethnicity, or gender. We do know, however, though, that men are about 1.5 times more likely to get Parkinson's compared to women. And part of this, we think, has to do with estrogen, since that seems to be somewhat neuroprotective. And the average age of diagnosis is around 62 years old. However, a small number of people can get Parkinson's at a pretty young age. So young onset Parkinson's, we think about that under the age of 50. You know, I personally have patients in their 30s, and we've seen people diagnosed even in their 20s. More commonly, though, people are over the age of 60 at the time of diagnosis. So what causes Parkinson's? Well, the cause of Parkinson's is unknown, but we think it's a combination of genetic and environmental factors that contribute to risk. So maybe an underlying genetic predisposition that increases your risk, and then maybe an environmental factor that the two together cause someone to get Parkinson's. We know that about 10 to 15% of people with Parkinson's have a gene mutation that has been associated with an increased risk of Parkinson's. And some of these genes you may have heard of, like LRRK2, GBA, we can actually test for them. And like Nancy was mentioning before, there is the PD Generation project that anyone can get involved with who has Parkinson's. You can actually be tested for these genes. And one of the reasons to think about getting tested now, for some of the genetic mutations, we can actually say, well, with this genetic mutation, you might be at a bit of an increased risk for some of these certain symptoms. But in addition to that, there are now clinical trials specifically for these gene mutations. So it's medications that are targeting what's going wrong because of the mutations in the genes. So if you know your gene status, maybe you know you have LRRK2, then you might be able to get involved in one of these clinical trials. Now, while we do know, again, like I said, 10 to 15% of people with Parkinson's have one of these gene mutations. If someone in your family also has one of these gene mutations, it doesn't mean they will go on to get Parkinson's. So there's something called reduced penetrance, meaning only a certain percentage of people with that gene mutation will actually go on to get Parkinson's. So it makes it more complicated. And at this point, we don't necessarily recommend testing people in the family without Parkinson's unless it's part of a study. And there are certain families that some of these genes seem to be passed down from generation to generation. So if you're of Ashkenazi Jewish ancestry, then you might be more likely to have a GBA or LRRK2 mutation compared to people who are not Ashkenazi Jewish. And aside from the gene mutations, we do know that there are certain occupational exposures to certain chemicals that seem to increase the risk for Parkinson's. So those can include things like pesticides, heavy metals, certain solvents. And there have also even been studies showing that air pollution has been associated with an elevated risk. And aside from these risks, older age is a risk, again, because we know people over the age of 60 are more likely to be diagnosed with Parkinson's. And then people who have had traumatic brain injuries in the past can be at an increased risk as well. So what's actually happening in the brain of people with Parkinson's? So Parkinson's occurs when the nerves and these nerve cells deep in the brain that produce dopamine gradually degenerate. So these neurons are either lost or they malfunction. And so over time, as you lose these neurons, we start to see some symptoms come out because of the loss of these neurons. It's been estimated that by the time someone shows the movement symptoms of Parkinson's, they've lost about 40 to 60% of those neurons. And with the loss of that dopamine production, you can see slowness of movement, trouble with speech, changes in sleep, changes in memory or thinking, and changes in mood. And we'll go through all these symptoms in a few minutes. And while we do know that dopamine is one of the main, it's called neurotransmitter that's involved in Parkinson's, there are also other neurotransmitters that are involved as well. And one of the main big goals of Parkinson's research is to figure out a way to slow or stop the progression of these loss of dopamine neurons. And in addition to that, we need to try to figure out how to identify people who are at risk for Parkinson's before they develop symptoms. Since we know by the time you're diagnosed, you've lost a substantial number of those neurons, we need to identify people way before then to try to keep as many neurons as possible. So what should you know about the symptoms? So there are different kinds of symptoms. The symptoms we typically think about are the movement symptoms. That's why it's called a movement disorder, because it affects the way people move. So that can include tremor or shaking of an arm or leg, slowness of movement, stiffness in the muscles. But in addition to the movement symptoms, there are also symptoms called non-motor symptoms, because Parkinson's itself affects many systems of the body. And we'll get into all of these as well. But those can actually be more bothersome than the actual movement symptoms. And what's also important to know is that the symptoms can vary from person to person. So not everybody has the same set of symptoms. And so as we go through these, just because I listed as a Parkinson's symptom doesn't mean if you have Parkinson's, you'll get that symptom. Okay, so the motor or movement symptoms. So like I mentioned before, shaking is one that people typically think about. And that is often of a hand, can be a leg, but can also involve the head, the neck, or even the jaw. And it is the most recognized symptom of Parkinson's. So oftentimes, if you're seeing your primary care doctor, they might recognize that tremor and then send you on to a neurologist. However, there are about 10 to even up to 30% of people who don't have tremor at some point during their Parkinson's journey. And sometimes that can lead to a delay in diagnosis if people aren't recognizing the symptoms. So in addition to the tremor, people can have slowness or trouble with movement, and that's something we call bradykinesia. And then they can have stiffness or rigidity in the arms, legs, neck, hips. And some people can actually experience that as a feeling of weakness because their arms, legs aren't moving as well. And then in addition to that, some people can have trouble with walking and balance. And then just something I wanted to mention was, aside from the tremor that we actually see, there are a certain number of people with Parkinson's who actually describe an internal tremor or a feeling of shaking that can be in the trunk or in the arm, but we don't actually see the tremor. But that is definitely a symptom of Parkinson's. And, these symptoms come on slowly. They gradually progress. So sometimes by the time we diagnose someone with Parkinson's, their family says, oh, you know what? They have actually been slower for a number of years. They've been lagging behind in walking, but because this was so slow, we didn't recognize it for a while. So in addition to those motor symptoms, there are the non-motor or non-movement symptoms. So these can include mood, so mental health problems. This can be depression, anxiety, or a feeling of nervousness or fearfulness, a lack of interest or lack of feeling. We call this apathy. So you can also think of it as a lack of motivation. So someone may look like they're depressed if they have apathy, but they're not actually depressed. It's just this trouble with motivation and getting to do things that you like to do. But once you're actually involved, still enjoying it. And this can be a very difficult symptom to treat. In addition to mood, people can have thinking and memory trouble, or what we call cognitive impairment. So people may experience this as trouble paying attention, learning new things, feeling like their thinking is just slowed down, or might have trouble remembering words or names. And then over time, a lot of my patients will tell me they just can't multitask like they used to. They really have to focus on one task at a time. And that can go along with some of the memory and thinking trouble. And other symptoms, and again, we'll get into some of these, something that can happen early on is softer speech. So people find that they're not able to project as well. They might have trouble falling asleep, staying asleep, or they might actually act out their dreams. And then a lot of people have trouble with fatigue or just feeling sleepy during the day. And then constipation is pretty common. And then usually later on, hallucinations can occur as well. So seeing things that aren't there. So these are the 10 early signs of Parkinson's. So signs that we can see early on. And these are, if you have one of these, it doesn't mean that you have Parkinson's. But if you're looking at this list and you think, you recognize a few of those symptoms in yourself, then it might be time to talk to your primary care doctor or even a neurologist to see if you might have Parkinson's. So one is the loss of sense of smell. That can actually happen 10 to 20 years before someone's diagnosed with Parkinson's. Constipation can also happen years before someone develops tremor or the other movement symptoms. And then a masked face. Oftentimes family members will notice that their loved one just isn't as expressive in their face as they used to be. And then stooping or hunched over can occur as well. So how do we diagnose Parkinson's disease? So currently there's no blood test to diagnose Parkinson's. It's all what we call a clinical diagnosis. So this means it's made by looking at your neurologic exam and your medical history, usually done by a neurologist. And, if possible, it's good to see a movement disorder neurologist. So someone who's done extra training in movement disorders like Parkinson's disease. So when you meet with a neurologist, they'll get a detailed history of your symptoms, your medical problems, looking for any medications, because medications that block dopamine can actually cause the symptoms that look like Parkinson's, but it might all be due to the medication itself. And then there are certain things that we look for on your exam to diagnose Parkinson's. So to be diagnosed with Parkinson's, you have to have slowness of movement. So that's one of the main things we're looking for. And then in addition to that, we're looking for the tremor, we're looking for stiffness, and then some people can have trouble with balance or what we call postural stability. And usually we're able to make a diagnosis pretty clearly and confidently on exam, especially if someone has these characteristic symptoms. However, there's sometimes when maybe someone has been on a medication in the past that blocks dopamine, or maybe their tremor just isn't quite typical. That's when we might go to something called a DAT scan. And I'll talk about that in a minute. Usually not necessary, but certainly can help support the diagnosis. All right, so the DAT scan, you may have heard of this, may have had one. So it uses small amounts of this radioactive drug to light up dopamine transporters. So dopamine transporters are on nerves and they take up the dopamine after it's done doing its job. So the normal scan will look like this comma shape. So if you have normal amount of dopamine neurons, normal amount of dopamine, this is what it will look like. In Parkinson's, because you've lost dopamine neurons, you won't have as many of those dopamine neuron transporters. So then we lose that comma shape and it might start looking like dots here. So that's someone who has a possible Parkinsonian syndrome. So if we thought, your exam really did look like Parkinson's, but we needed confirmation, if we got this DAT scan, we could again be pretty sure this was Parkinson's. However, it doesn't guarantee that someone has a diagnosis of Parkinson's because these scans can be abnormal in other disease states, such as atypical Parkinsonian syndromes. So again, this is not a substitute for a thorough examination by a neurologist. Usually we can pretty easily make the diagnosis clinically, but if there are questions, atypical symptoms, then this is something that someone might recommend for you. So one of the big questions I get asked quite frequently is, when should I start treatment? And does starting treatment now mean I need more later? So the decision of when to start treatment is really a discussion between the neurologist and the individual. So it is different for everyone, and it depends on that person's individual needs. So I usually talk with people about whether their symptoms are interfering with their daily activities, Is it making it difficult to exercise? And that's something we'll get into as well, but exercise is the one thing that can actually slow progression. So if your symptoms are starting to interfere with your ability to do that, then we really need to start thinking about starting a medication. Now, again, it'll be very individualized. I have patients who, have significant tremor. They say it doesn't bother them, it doesn't interfere with activities, so they want to stay off medications for a while. Then I have patients who they're still working. Maybe they're just having some subtle trouble typing, using the mouse, but it really is interfering with their work. So they might want to start medication much earlier. And so again, talk with your neurologist about what's bothering you and whether or not you think you're at the point that you need to start medication. So if you're diagnosed with Parkinson's, one of the main things you want to do, aside from finding a neurologist, preferably someone who has specialized in Parkinson's and movement disorders, is going to put together a healthcare team. So as we talked about before, it can affect pretty much all systems of the body. So there are other specialists that you might need to see at some point during your journey with Parkinson's. And this is something that a primary care doctor and your movement disorder specialist can help connect you with these other specialists. So this might include physical therapists, they'll be very important, as well as occupational therapists, speech language pathologists, social worker who can help find resources in the community. There are often counselors as well who can help with mood, anxiety, depression trouble, and then a psychiatrist or a psychologist as well. And then because people with Parkinson's tend to be on more than one kind of medication just for Parkinson's, a pharmacist can be helpful too. And we'll talk a little bit about diet and lifestyle changes, but some people do find it helpful to meet with a dietitian as well. Some people might have fitness professionals or personal trainers. And then if you look in the community, there's usually many support groups, community health workers, professional caregivers. You might have a big team working with you to make sure you're living as well as possible with Parkinson's. So when we think about symptom management, like I mentioned, finding the right doctor is really important. So you want to find someone who is a neurologist and sees people with Parkinson's, and preferably if there's someone in your area, someone who has that extra training in movement disorders. So it can be kind of overwhelming to try to find someone with this training. So you can start by just calling the helpline through the Parkinson's Foundation, so they can help match you up with someone who's close to your area. There aren't always movement disorder specialists in everyone's area. So one place to look could be Parkinson Foundation Centers of Excellence. So see if there's one near you. And if there's not, oftentimes movement disorder neurologists can do telehealth. So you can meet with them through or virtually through a screen. And then oftentimes, even if you're meeting with them through telehealth, seeing them in person, so a full exam can be done, and they can see you in person, can be helpful maybe once or twice a year. And it's not uncommon that I have people coming in, they might be driving hours and hours, flying in once a year, so we can provide some advice, recommendations for their care, and then they might see their local neurologist for the other visits during the year. And we work together to make sure they're getting the best care possible. And, just some support for trying to find a neurologist. There have been studies shown, or studies that show that people who see a neurologist with Parkinson's actually live longer, and they're less likely to need placement in a nursing facility and less likely to have injuries like a hip fracture. So the literature or research does support that people do have better outcomes when they see a neurologist. All right, so now we'll get into the treatment options. So we'll talk about medication and surgical treatments. So medications can be for the motor symptoms and the non-motor symptoms. And the surgical options are mainly for those motor symptoms. And then, like I mentioned before, exercise is going to be really, really important. And then the therapies, physical therapy, occupational therapy, speech therapy, also very important parts of care. And then counseling and therapy can be very important. So this is just a short list of some of the medications that can be used for Parkinson's. Levodopa was the first medication discovered for treating Parkinson's disease. It's still the best medication that we have. Now, however, we have it in many, many different formulations. We even have an inhaled version now. People with Parkinson's do tend to take more than one type of medication. They might take it at different times of the day, different doses, and it's really finding that individualized regimen that works for you. And some of these medications, again, levodopa, it's converted to dopamine in the brain because dopamine itself cannot pass through what we call the blood-brain barrier. So it's kind of the safeguard that the brain has, but levodopa can. And once it gets into the brain, it becomes dopamine. Then there are medications called dopamine agonists that act like dopamine. So it's not dopamine itself, but the nerves think that it is similar to dopamine. So it acts like dopamine and has similar effects. And one to talk with your doctor about because they can have more side effects than some of the other medications. And then there's MAO-B inhibitors. So those are things like rasagiline, selegiline. They block the breakdown of dopamine in the brain. So keeping it around longer so it can act longer. And then COMT inhibitors, they're combined with levodopa and they keep the levodopa around longer and increase its benefit. And there are a bunch of other medications that have come out over the years. So you can look at the Parkinson's Foundation Guide to Medications. You can look on the website and read all about them. And one other to think about, we do have others that are up for FDA approval right now. So there's a subcutaneous pump where it's a liquid form of levodopa that is just pumped right under the skin. It can be worn for 24 hours a day. And that, look out for in the next year because currently at the FDA, so we'll see if it gets approved in the next year. So aside from medications, surgery is also an option for Parkinson's disease management. Usually we're thinking about things like deep brain stimulation surgery when someone's been on medications for a while, and maybe the effect is wearing off after a few hours, or you're having to take medication 4, 5, 6 times a day to get the same effect. You might develop dyskinesia or extra wiggly movements. And so deep brain stimulation surgery can be very helpful for those. And if it's in the subthalamic nucleus, you can actually decrease the amount of medication you take by about 50% or more. So if you're having side effects from medication, by decreasing it by 50%, those side effects actually get better as well. When we think about what deep brain stimulation surgery can do, it's usually what responds to the levodopa. So tremor, stiffness, slowness, all those symptoms that get better with levodopa tend to get better with deep brain stimulation surgery. Now, aside from DBS or the deep brain stimulation surgery, there is another surgical procedure called Duopa. And this is a gel form of levodopa. And it's delivered right to the small intestine, which is where levodopa is absorbed. It does require a PEG tube or a feeding tube to be placed. It's placed in the abdomen or through the abdomen to the stomach, and it stays in place all the time. And the medication can be pumped in for up to 16 hours per day. And again, this is mainly used to treat those motor symptoms. And because you're getting a smooth delivery throughout the day, people see less of the ups and downs. So less time with medication wearing off, less of the dyskinesia. And of course, surgery isn't right for everybody. So if you're at the point where maybe medications aren't working as well, they're wearing off, definitely talk with your doctor about some of these options. One other that I wanted to mention that has been approved more recently is focused ultrasound. So this is a one-time irreversible procedure for Parkinson's, mainly used for Parkinson's tremor. So it involves being in an MRI. You've got this big cap on, some cooling liquid running through there, and it uses these ultrasound beams, so over 1,000 of them, that are all concentrated on a specific area in the brain, and it creates a thermal lesion. So you're heating up that area of the brain until we see reduction in the tremor, and then we can heat it up enough to cause a lesion or cause a small set of those cells to die. And that disrupts some of the abnormal circuits, and we can see immediate improvement in the symptoms like tremor. Some of the advantages of focused ultrasound is that it doesn't require any surgical incisions, doesn't require any hardware. You're not having to come back for programming. It's one time and it's done. Some of the downsides are, though, Parkinson's does progress. So we might see some of these symptoms come out again in the future. And, at this point, we're still learning if people can be retreated with focused ultrasound. But we don't have anything like in DBS where we can actually make some changes to settings. Currently, it's only approved for treatment on one side of the brain. So it'd be choosing, tremor on my right side is what really bothers me, then maybe that would be the side that you choose. There are studies underway to try to figure out if we can safely treat both sides. All right, so aside from medications, one of the big forms of treatment for Parkinson's is exercise. You'll probably hear that a lot. I know I've already said it a lot, but again, it's the one thing we know can actually slow progression. So from the Parkinson's Foundation and the Parkinson's Outcomes Project, they show that people with Parkinson's who started exercising early after diagnosis and for at least 2.5 hours a week had a slower decline in quality of life compared to those who started exercising later. And again, because it can slow progression, it's something that you want to keep up with. And so we'll talk about this as well, but establishing these habits early on is very, very important. So some of the benefits of exercise, it can help with balance, mobility, maintaining strength, flexibility, and it can also ease some of these other non-motor symptoms like mood. So it can improve mood, can improve constipation. And we also find, because of the stiffness or the rigidity that can come on with Parkinson's, flexibility or stretching exercises can be really helpful for that. And then you also want to include some aerobic activity, which can be things like walking, running, and then some resistance training. So keeping up your muscle mass. Doesn't need to be big weights, but just some kind of weight resistance. And again, biking can be a really good exercise. Tai Chi is great for balance, yoga, Pilates, pretty much any activity that you like doing. And again, that is what I tell my patients. You want to make sure it's an activity that you like, because that's something you're more likely to stick to if you enjoy doing it. And that's what's most important, that it becomes something you do and becomes a habit. So some of the other therapies that I was talking about before that are really important in Parkinson's disease management and making them part of your healthcare team are the physical therapist, occupational therapist, and speech therapist. And usually your doctor is going to be looking, at least once a year, whether or not you would need a referral to one of these specialists. And then, of course, if you bring up something like balance trouble, then we would probably be sending you to see a physical therapist. So a physical therapist, the goal in working with them is to keep you moving as well as possible, as long as possible, and just overall enhancing your ability to move. They may work on big steps, big movements, and they can also be really helpful in working on balance. And as far as occupational therapy, they will help you identify strategies to continue doing the activities that are really important to you. So this might be changing the environment, adapting certain activities, but definitely a therapy that we want to keep in mind. As I think we tend to send people to physical therapy and speech language pathology, but occupational therapy can be really helpful as well. So when might you see a speech language pathologist? So two main reasons. So because people with Parkinson's can have that softer voice, it's harder to project. The speech therapist can actually do exercises with you and give you exercises to take home that can help you with that projection. And with speech therapy, we've seen from studies that it does actually really help with the loudness of somebody's voice. But what's really important is that you continue those exercises every day, even once you're done with seeing the therapist. The other important reason to see a speech language pathologist is if you're having any trouble swallowing. So if you're noticing when you're drinking or eating, you're starting to cough more or even choking, definitely good to get in to see one of them so they can see what the problem is and then help you swallow safely. So this is another finding from the Parkinson's Outcome Project, is that depression and anxiety were the #1 factors impacting the overall health and well-being of people with Parkinson's. So these are those non-motor symptoms that you can't necessarily see, but tend to have more of an impact on people with Parkinson's than the actual movement symptoms. So it's really important if you're having any of these symptoms, one, to let your doctor know, and two, to get the help that you need. So this can be through a psychologist or a psychiatrist to help with medication, support groups, social workers. And the goal for the person with Parkinson's is to treat these mood disorders, so to get them under as good control as we can. And then you can also discuss the challenges of living with Parkinson's, and they can help you build these coping skills to help you throughout your journey with Parkinson's. Because Parkinson's is a journey, challenges will change over time. And so having a counselor or someone that you can meet with regularly can be really helpful. And then Parkinson's doesn't just affect the person with Parkinson's, it affects the whole family. And so it's important that the care partner, family, friends, whoever's involved in the care of the person with Parkinson's also make sure they get the support that they need. And so the goal, again, seeing any of these mental health providers is to preserve and support the emotional well-being of the family member or the care partner. And as you heard before, there are care partner symposiums, care partner support groups, so a lot of resources for people to reach out to. So here is just listed some of the challenges that can come with coping with Parkinson's and some of the things that you can do to try to approach and overcome these challenges. So if you have Parkinson's, you may know it can be unpredictable. So how you do one day might have to do with how you slept the night before. Is medication kicking in like it should? And so trying to get comfortable with this uncertainty, you might need to go with the flow a little bit more. So depending how you're feeling, you might not be able to get everything done that you wanted to do that day, and being okay with that and being okay resting when you need to. And then some people can feel a loss of sense of control. And so things that you can do, take ownership of your exercise routine, make sure that you're exercising at least those 2.5 hours a week. And then, working with a counselor, working with others, you can change the way you think about Parkinson's and your attitude towards approaching each day, just to make sure you're living as well as you can with Parkinson's. And one of the big concerns I hear about often is concerns about independence. So something to think about, talk about with your family, what does independence mean to you? And then think about ways that you can maintain your independence with support from loved ones. So what do you need from your loved ones? What do you need potentially from outside help to maintain your sense of independence? Another one is lifestyle. So, rather than stopping things that are hard, it might just be making the right adjustments. So being able to continue the activities you like just might look a little bit different. And then roles change over time. So you might even just create a new role. Some people with Parkinson's, if they're diagnosed, age 60 or maybe even before then, might end up retiring earlier than they otherwise would have planned. But you can look for other activities, potentially even volunteer opportunities that are fulfilling to you. And so just reimagining, what your role is and what you want to do. And then lastly, identity. Reflect on your identity. As things change, think of it as an opportunity to look at things in new ways. And all of these challenges, trying to meet these challenges is where, again, counselors, psychologists, support groups can all be very, very helpful. Because again, there are a lot of challenges that can come along the way, and they change over time with Parkinson's. So lastly, I just wanted to mention research in Parkinson's. There is a lot going on, and it does play a vital role in helping us understand Parkinson's and work towards a cure. So research leads to new treatments, new medications. There are a lot of trials underway now to look for those neuroprotective medications or things that can slow down or stop the progression of Parkinson's. It again leads to a better understanding of our symptoms and of disease progression, and again, ultimately brings us closer to a cure. So ways you can get involved: if you go to clinicaltrials.gov, you just type in Parkinson's disease, and it will bring up trials that are going on for Parkinson's disease. You can also put in your location so you can see ones that are going on in your area. And as always, you can always call the Parkinson's helpline. So you can let them know you're interested in certain kinds of research, and they can try to connect you with people in your area. And your doctor can always be a good resource as well. And a lot of the Parkinson Foundation Centers of Excellence do have clinical trials and other studies going on. Which just brings me to the type of clinical studies. So a lot of people think of research as you're getting either a placebo or a medication, but there are a lot of studies that are actually observational studies. So these are just what they sound like. Participants are being observed. So we might collect data, questionnaires, blood work, certain kinds of images like MRIs or DAT scans, but you're not exposed to an intervention. You're not getting a medication. And oftentimes we're comparing one group to another. So if we compare people with Parkinson's and people without, what are the predictors that someone might actually develop Parkinson's disease? So those studies can be very, very helpful and give us a lot of information about Parkinson's, but doesn't require that intervention or medication. But then there are people who are very interested in potentially getting some of these new medications that are coming out in trials. So that would be through a clinical trial or an interventional study. And that's where you're usually either assigned to an intervention group where you're getting the new study medication, or you might be assigned to the placebo group, or what we might call the standard care group. So maybe we're comparing a new medication to carbidopa-levodopa or Sinemet. And some of the advantages of being in one of these trials is you might get one of these new medications before it ever comes to market, and it might improve your symptoms. But you might also be in the placebo group. But in general, for both types of studies, you're contributing to the knowledge about Parkinson's disease in general and helping the Parkinson's community in general. All right, so this brings us to the end, and we'll get to questions in a minute. But these are just some of the takeaway points from what we've talked about today. So Parkinson's disease symptoms, there are quite a few of them, but they can be effectively treated. So it's important to see a neurologist, someone familiar with Parkinson's, so that you can make sure your symptoms are treated as well as possible. Symptoms do vary from person to person, and they can include those motor symptoms and those non-motor symptoms. So if you're having a new symptom, you're not sure if it's related to Parkinson's, just let your doctor know, because it certainly could be. And then a personalized treatment approach with a comprehensive team is what helps individuals with Parkinson's have the best long-term outcomes. So again, even if you're only able to see that movement disorder specialist once a year, they can make recommendations, look at your medications, your exercise regimen, and make sure that everything's optimized for you. And as we talked about, a support network is really helpful for the person with Parkinson's and for their family. So, finding resources in the community, other family, friends, and just creating that network can help you. All right, and with that, I will end, and then we can start taking questions.
Wonderful. Thank you so very much, Dr. Fullard. That was fantastic. We have great comments, questions submitted during registration and during the webinar. So let's get to it. First, I'd like to remind everybody that don't worry too much about trying to capture every single note. This is all being recorded, and everyone who registered will receive a follow-up email from us in about a week that will include a link to the recording of this webinar, so you can review all of it, parts of it, and any of the resources that we mentioned. So I wanted to share that and remind everybody about that. So once again, great questions that we have here. So can you go back through and tell us, someone asked, why is the number of people with Parkinson's expected to increase in the coming years?
Right. So great question. It really is because people are aging. So there's a larger group of people now who will be in their 60s and above in the next 15 years. Mm-hmm. And then part of it is because of industrialization, we think, and more exposure to some of these environmental factors. And then people are living a little bit longer as well.
The age wave, I guess we can refer to it as, right?
Yes.
So one of the great things you did in updating our coverage of this topic, you included the information on focused ultrasound. So if someone was interested in that, how do you get it? Where is it available?
Right. So great question. So you can go to the Focused Ultrasound Foundation website and go to Parkinson's disease, and they'll give you a list of the centers that do focused ultrasound. One of the things you probably want to look for is that there's a combination of a movement disorder specialist and a neurosurgeon who are working together, because they can make sure that you're an appropriate candidate and that your outcome can be as good as possible. And
we can include that website in our follow-up email, the list of resources. Would it be a correct assumption that talking with your neurologist or if you see a movement disorder specialist, that they too might be involved in that decision and that conference process?
Right, exactly. So if you're seeing a movement disorder neurologist or a general neurologist, definitely discuss it with them. You might be at a center that is doing focused ultrasound, so then they could do the actual evaluation process there. If not, then they'll have information about where to refer you and where to send you if they think you're an appropriate candidate.
Okay, great. So I'm just going to keep going through our questions. They switch gears, so bear with us. This I think is a good and important question, and maybe we're not exactly the right people to answer, but I want to bring it up. So you covered, and I kind of mentioned it in the beginning too, in terms of there's different types of treatments, different drugs, counseling, physical therapy, occupational therapy, all those complementary things. What's covered by, say, Medicare or private insurance? Can you speak to any of that?
So, just in my experience, a lot of it is covered. So physical therapy, occupational therapy, speech therapy is all generally covered. And if there are questions about coverage, we usually get our social worker involved to work with you beforehand. But usually once we send a referral, an authorization process, there is a process to go through to make sure it's covered before actually starting any therapy, so that you're not billed on the back end.
Okay.
Counseling, mental health. I mean, we don't always have the best coverage in this country. That would be something to check on, maybe working with a social worker to try to find someone who might be covered. Psychology Today is actually a really good resource.
Yes.
You can put in, where you live and the kind of either counselor, psychiatrist, psychologist that you're looking for.
Excellent. I'm making notes of all these things that will continue, or that will include in the follow-up email. Another question, and this comes up a lot in many of the programs that we do. What about vitamins or complementary therapies?
Yes.
How do they help or not help, or is there
Right.
any evidence to support their use?
Yeah. So that's a great question. At least as far as some vitamins go, we do recommend that people with Parkinson's on levodopa take vitamin B12, because your body actually uses B12 to break down levodopa. And so people with low vitamin B12 are at risk for neuropathy, and it can also affect memory and thinking. So that is one supplement we do recommend. People with Parkinson's tend to have lower vitamin D, and that can be associated with risk of fracture. So we recommend having your vitamin D checked and being on vitamin D supplements if it's low. And even being on 1,000, 2,000 units a day can be helpful, and it's unlikely to make you too high on your vitamin D. As far as others, we have more research, even here at the University of Colorado, looking at marijuana, CBD. We have evidence that can help with pain, with sleep. We're looking at whether it can actually help with the other symptoms of Parkinson's, like tremor. So we have some studies that are finishing up now. So hopefully we'll have some of those answers.
Oh, good.
And then one question I get a lot as far as complementary therapies is mucuna. You may have heard of that. It's kind of a natural source of dopamine or levodopa.
Yes.
It can certainly treat the symptoms of Parkinson's. And I do have patients who prefer to be on that in the beginning. What can be difficult is we don't always know exactly how much is in there. So we don't know how much levodopa you're getting. It's hard to make changes in the medication. But it is certainly something that some people do choose to use.
Okay. All right. Very good. So let's talk for a few minutes about exercise. So someone has heard that there's something about boxing and Parkinson's that's good, but that doesn't make a lot of sense in some ways. So what do you know about boxing as a form of exercise?
Yeah, so there's one program called Rock Steady Boxing, and you're not boxing other people, so people aren't hitting you, but it might be, boxing in the air, boxing with a bag. But what we find, it actually really helps with balance. That's one of the things a lot of people go to those classes for. And in addition to that, you are in a class with other people with Parkinson's. They kind of become your support group. You're working with others. You can feed off their energy. And a lot of people just really like it. They enjoy it. Something different than they've ever done before. And I mean, it can help with strength. It can help with movement. And with a lot of these classes, it's just trying some and seeing what you like, because any exercise will be better than no exercise, for sure.
Okay. So would I be correct in saying that that's the bottom line? Moving exercise of any kind is so much better for people with Parkinson's.
Right. Which is why it's so important to pick something you like, something you enjoy. Because if you're trying to force yourself to do what you think is the exact right thing, but you don't enjoy it, you're probably not going to stick with it.
Right. Yeah. Kind of makes matters worse in many ways. So one of the things that has come up as well, and it's connected to exercise, but it's also related to the mood questions of, I'm feeling too depressed. Is it really Parkinson's symptom, or could it be, that it's a reaction to, because I don't want to exercise. So Have you had folks in that situation? And if so, how do you go about addressing that?
So some of it is figuring out, is this soon after a diagnosis of Parkinson's? Is this the normal grief process that you can go through after a diagnosis? Because it is kind of a loss, grieving a loss of, what perhaps you thought your life would be, and kind of readjusting and rethinking what your life will be now. So grief is normal, and, working with counselors, we have a great neuropalliative clinic here that we will send people to, but making sure that you're getting the help that you need. Because if you do have depression, and that certainly can be from Parkinson's, we want to make sure that's treated. Because if you're not exercising because of that, then we're not slowing progression like we could. But in addition to that, there are people who, their family might be worried that they're depressed, but it's more that apathy. So just that lack of motivation. Once they actually get there, they definitely enjoy it. They like doing it, but it's just that getting over that hump and getting there. And that's where things like having a calendar, so putting it on there, and maybe you do it Monday, Wednesday, and Friday, and it just becomes habit for you. Or if you're someone who likes making lists and checking them off, if that's motivating to you, that can be helpful. But just trying to come up with routines and making things as habit forming as possible.
So you come routine. Sure, that
Right.
makes sense. So, Dr. Fullard, when I introduced you, I mentioned that your primary research area of interest, I believe, is the gender differences between men and women living with Parkinson's. So can you talk about that for a few minutes and help educate us about, are there differences? What's going on there?
Yeah. So there are some studies showing that women are diagnosed about 2 years later than men. Some that haven't shown quite that. So there's a little bit of controversy there. And women are actually more likely to have tremor compared to men, and more likely to present with that tremor. And then, one of the reasons we think women may present later on is because estrogen can be neuroprotective. So it can actually protect those dopamine neurons. So then when women go through menopause, they then become at higher risk for developing Parkinson's. And there are studies going on. Again, we don't really know right now, but if you do go through menopause, perhaps hormone replacement therapy at the exact right time can also be neuroprotective, but we don't know yet. So we don't know enough to actually recommend it at this time. But we do know people who go through, say, surgical menopause early are at higher risk for Parkinson's than people who go through natural menopause later on. And then, there can be differences in the motor and non-motor symptoms as well. There's some question of whether women progress less quickly. That might be because they are more likely to have tremor. And then they tend to have more of the anxiety and depression compared to men.
Sounds like, although there's still much research to do, it sounds like we really are learning more and more, which hopefully will help us figure out why this is happening in the first place. Exactly. So that's great. Very genuine concern here is a question about, do you think I'll have to give up driving?
And that is something that we hear quite frequently because it's something very much tied to independence. So because Parkinson's can affect reaction time, it can cause slowness of movements, difficulty moving the head back and forth. There may be a time where someone does need to stop driving because it can also affect memory and thinking. That can also be a concern. So usually it's an ongoing conversation with your neurologist, ongoing conversation with family too, if they're noticing near misses or if there are concerns. And it's not necessarily, we say, okay, right now you have to stop driving. There are occupational therapists who can do driving evaluations. And then there are on-road driving tests that can be done. And so they might say, you know what, you can drive, but maybe we're going to limit it to a 10-mile radius around your house, or no night driving. So it might just change over time before completely stopping. But definitely a conversation to keep having with your neurologist.
Excellent. Okay. Excellent suggestion. So that can connect to sometimes family members being involved, concerned. And a lot of the comments people hope to learn in this session when they registered were about coping or talking with my family. So as a practitioner, seen lots of people with Parkinson's, Are there any things that you recommend in terms of preparing to cope with this, managing family dynamics in terms of their reactions, talking to family members?
Right. So, I mean, a lot of it is going to be open dialogue and communication that might even be, with help from, community resources, mental health professionals, but just keeping that line of dialogue open because roles do change over time. Someone with Parkinson's might have a caregiver role, and then as the disease progresses, might have to start receiving care, and that can be hard. So just maintaining that open communication. And then for the care partner, making sure you're taking care of yourself too. It can sometimes be overwhelming if, say you're working full time and then you're coming home and you're helping with a lot of extra things.
Yeah.
So making sure you're taking time for yourself. Maybe it's having help in the home every now and then so that you are able to get involved in self-care and, maybe even seeing a therapist or counselor yourself too, to help. And then there are great symposiums and support groups, and talking with others going through the same thing can be really helpful too.
Absolutely. You made that connection with what can happen when people participate in rock steady boxing classes or groups. The support of that kind of network of people who know exactly what it means to have a tremor or to experience this, so invaluable. So in our remaining, we just have a few moments left. You have done such a fabulous job. You've encouraged folks to contact our helpline, investigate whether they are close to or could access one of our centers of excellence. And I wanted to mention that this is all very brand new, that as I mentioned, in terms of our mission, it is to improve care. And that's kind of tough because we don't have a lot of Dr. Fullards out there across the country. So we now have an additional level of care. In addition to our centers of excellence, we now have comprehensive care centers. So I would encourage anyone, if you're calling our helpline, check out both centers of excellence, now our approved comprehensive care centers, because those would be, as Dr. Fullard had said, a great way to seek care if you're living with Parkinson's. So, Dr. Fullard, any other closing comments or remarks you'd like to make?
I think the main thing is just, seeing a neurologist, movement disorder specialist, and then just getting that team, getting that support. So you're not alone in this, and you don't need to be alone in it. So just get that support network and live as well as you can.
So perfect. That is our message all along. Thank you so very much for working with us, for presenting today. We are so appreciative of you being here. So thank you so much, Dr. Fullard. And thank you to all of you who joined us today. We hope that this has been really very helpful for you as well. So one of the things that we ask is if you would give us your feedback. As our program concludes, a window will open up with a link to complete a survey or an evaluation of our program today. And we take this very seriously. We use these evaluations to plan future programs and improve all that we do. And just a reminder, our program was recorded. A link to the recording will be sent to you via email in the coming days, usually at least a week. And all the resources. And I made some notes here, so I'll include those as well, the things that Dr. Fullard mentioned. So that will be coming to you very, very soon. And lastly, just as Dr. Fullard just said, literally, you are not alone. We are here for you. The Parkinson's Foundation provides so much, has so many resources. Please reach out. Visit our website, parkinson.org. It is just a compendium of information and resources. Pretty much anything we print is available digitally. You can also call us on our helpline. Our helpline specialists are wonderful, fabulous people. 1-800-4PD-INFO. You can also email our helpline at helpline@parkinson.org. So please contact us. We want to be there to support you. And if we didn't get to any questions you had, use those resources as well to follow up. So we thank you again for joining us today. So very happy to have you with us. And please stay connected. We will be here And we look forward to connecting with you again. Thank you so much.